The airway is really the essence of life.
Yeah,
if we can't breathe at night, and again, back to the tube, it's not a rigid tube. The tube collapses when the muscles around that tube are flaccid. And that is the definition of deep sleep, when all our muscles are paralyzed. They literally just let go. The question we should be asking is, why am I so tired? But then how do you relay that to your physician? You know, do you ask them for an Epworth? Do you tell them you have a small airway and that you grind your teeth and you have a scalloped tongue and all those things? No, you don't, because you don't know that. But your dentist does, and your dentist can guide you. Lingual erosions, dry mouth in the morning, bruxism, GERD, patient complains of GERD. It's on our form for sleep apnea.
Dr. Burhenne, it's great to have you on High Intensity Health Radio.
Thanks for having me.
You know, it's very interesting that we're having this discussion right after I was telling you about the Institute for Functional Medicine meeting that I was at in San Diego. And the whole topic was about sleep and circadian rhythms and how sleep can perturb our metabolism, cause inflammation, cause intestinal permeability, affect our energy. And a big aspect of your clinical practice as a dentist is really looking at the mouth as a gateway to sleep dysfunction. So I would love to know kind of the backstory on that. You wrote this great book, The 8-Hour Sleep Paradox, but tell us a little bit how you got into looking at sleep in terms of like oral health.
Well, first of all, I'm glad it was all about sleep, because I think sleep is really the foundation of a lot of things. As you mentioned, oral microbiome, gut microbiome, mood, how we look at the world, everything. But the oral systemic connection, I feel, has been ignored for too long. You know, partly our fault. I mean, we've known about it for a while. There's been that, you see it in the media, you see, you know, if you have gum disease, you may get heart disease, and then it kind of stops at that. So, but it's a very complex communication between what happens in the mouth, happens in the body. Most of us will get some ramification of it. It's just the nature, it's one of the weak spots in our body. And of course, our lifestyle and our environment these days is not conducive to that weak spot in our body. And that weak spot is the I guess that you could call it just the proximity of the blood supply to the oral environment. And the mouth is a unique place. It is really the only place where a non-shedding bone-like surface protrudes out to the outside of the body. I mean, it's not the outside of the body, but it's, you know, it's pretty close. Right. Fingernails are different. They're growing, you know, but this is it's like having a feeding tube. You know, people get infections around feeding tubes. The body isn't good at letting something break through the skin and keeping it clean. So that's the challenge that the mouth has. And of course, there's food coming in. You know, we wake up with dry mouths in the morning, which, you know, creates a different, you know, flora or microbiome in the mouth, and it drops pH levels, which, you know, and this doesn't happen in the gut. The gut has the stomach in front of it. It has a lot of filters before everything gets there. But the mouth is, you know, we're breathing in cold air. We're taking in mouthwashes that are caustic and like little nukes that go off in our mouth that are killing everything. I mean, it's just a crazy place. And then you've got dentists, you know, tinkering around in there. So it's a unique part of the body, and it undergoes kind of a lot of issues that have to be maintained and addressed. And unfortunately, our current methods are, I think, most of the time are just, you know, inadequate and actually, you know, wrong. I mean, killing things in the mouth to achieve better health. That, I mean, would we be doing that to our gut?
Right.
Well, that's what an antibiotic does, right? And would we? It's like taking an antibiotic all year long. It's the same thing. The mouthwash is doing the same thing. It's killing the bacteria. It's putting them down, and of course, then it promotes growth.
Right. And
then it promotes the wrong growth and the wrong ratios. So the mouth is a very unique place, and what happens in that zone, which I can describe, you know, in more detail, the mechanism of how those bacteria get into the blood supply. I mean, that causes other diseases like heart disease, Alzheimer's, diabetes, or insulin resistance. You know, I mean, they're pancreatic stuff, intestinal things. Right. We're just beginning to learn the effect on the gut microbiome. And we do know that the oral microbiome and the gut microbiome are linked. It's about a 40-50% overlay. So if something's wrong at the open end, at the beginning, you know, how does that affect the gut? And we're just kind of on the verge of making good discoveries in that area.
Yeah, it's pretty fascinating. So let's kind of get an overview of the landscape, if we could. I know a lot of our listeners are familiar with the gut microbiome and the 100 trillion single cell bacteria, but give us an overview. Are they mostly aerobic, anaerobic? How many bugs do we have here? And then what are the things that kind of perturb the oral microbiome?
So it's similar to the gut microbiome. Different. I mean, there's an overlap of 50-60%. There are a lot of anaerobes and aerobes. The bacteria are unique, a lot of them, but there are a lot of like bacteria. Again, there's that overlap. The uniqueness, of course, comes from the fact that we're breathing in air. It's a drier environment. We've got saliva. We're not dealing with gastric, juices and acidic kind of things. Acid actually is very bad for the mouth, so it's a different environment. And there are a lot of external influences. What kind of mouthwash you use. You were mentioning that. I mean, we are blowing it up in there. We are really creating havoc. We're making it actually worse. Our bodies are trying to reach this healthy, homeostatic kind of healthy stage where the anaerobes and the aerobes and the strep mutans isn't too high and other bacteroidetes groups are higher and managing everything. And that can work on its own, but then we're interfering with very strong caustic chemicals, alcohol, ethanol, triclosan. It's a pesticide, and there are other things. And then we put abrasives in there, and then we put in surfactants and chemicals that help make big batches of toothpaste so that it's all mixed properly. But it's an emulsifier, and of course emulsifier is up against the cell wall. That's how we break down cells. That's one way we do that. So I think it's really haphazard and reckless of us. But we've always kind of gone along that, rinse with this mouthwash and it'll kind of have a strong bitter taste, and it's got a kill rate of
99
50, yeah, exactly, right. But it's only for 20 minutes, and then what happens after the 20 minutes is over? And does your breath actually smell better? It probably smells worse because you've just messed the whole environment up. And the sulfide bonds, which is the more odorous part of our breath, that's changed. You've messed with what the body's been trying to establish. And then of course feeding. So the way to deal with that is not to kill everything, but to nourish it, to feed it, not kill it. And of course, but then there's a good diet for that, and there's a poor diet for that. So.
Yeah, I guess let's talk about diet a little bit. The lower carb, higher fat, higher vegetable. The diet that's good for our microbiome, right, is probably good for our oral microbiome. Yeah.
Yes, and it took me a while to get to this. It was always you could take vitamins and you could just eat well, but you have to take it one step further, and that is a paleo or ancestral diet is ideal. Our bodies and our mouths. The oral microbiome, the biome itself, has evolved to a certain diet, and it depends on who you talk to. 100 years ago, 200 years ago, it depends on which stage of how we changed our food source. 10,000 years ago, we started farming and modifying grains and all that. So, but changes occurred, and our bodies tried to respond to that, and certain genes expressed when they wouldn't normally, and that's when the problem started. So it's diet is big, and if you eat the right diet and stay away from all those things I was referring to, the mouthwashes and the toothpaste and many other things, ingestion of plastic beads that are in our toothpaste that make it look nice when it comes out of the tube. But we've actually found those little, they're called microbeads, I think. They were just outlawed in California. Little small beads, which I had to get my big macro camera out and just to get a picture of it. They get caught in between the sulcus, between the little fold between the gum and tooth, and you've got a foreign body reaction. The body's responding to something that it can't break down. Other things will get caught in there, like a poppy seed.
Yeah,
that's that little connection, to the rest of the body, and the bloodstream's on the other side, and there's a foreign body response, but the body can break it down with enzymes and its immune system. But a microbead made out of polyethylene,
that's incredible.
If we don't find that, it doesn't break down, and the body will maybe wall it off, or maybe there's some fibrous scar tissue that forms, and then the vascular supply to that is different, and then you get constant bleeding and inflammation. And so there's good diets, bad diets, and then there's everything else. So,
right.
Yeah.
So let's kind of finish off here and talk about oral health a little bit. So floss or no floss, because I've heard different opinions actually in the integrative space, that you shouldn't floss because it may perturb the oral microbiome.
Right.
And then safe and acceptable water pics, I've heard that, with hydrogen peroxide or without. There's like two different schools of thought there.
Right.
So let's kind of tackle that. I think it's
that's a good question. I think we've confused a lot of people, and it's not just dentistry, it's also the people that are trying to sell dentists things. They claim they have good products, and do you add hydrogen peroxide to your water jets? And so I have my opinions on that, and I try and base them, back them up with facts and studies. So essentially, so the water jets, the water pick, that's a good device. You have to be careful with that. If you angle it the wrong way and build up water pressure in such a way, you can tear the tissue away from the tooth. It's unusual, but it can be done. And also adding hydrogen peroxide I would not recommend. It creates a free radical reaction, creates a lot of oxygen. That's why a lot of dentists like it. And then the aerobes die, but some of those, the anaerobes, but some of those anaerobes are useful to us. So again, that's a little bit like swishing with alcohol or triclosan. It's a little bit of a gamble. So I don't recommend hydrogen peroxide. But things that stabilize the pH in the mouth, like baking soda, maybe some salt, Himalayan salt, you can rinse with that. That's fine. I'd be careful with the surfactants in toothpaste. They can modify things. So it's you mentioned flossing. That's the big one. So brushing and flossing essentially cause a bacteremia. Bacteremia is where you get bugs from the mouth into the blood. And that happens with a cavity. That was something new to me. I just read a study on that about 10% of kids that have cavities have a bacteremia, chronic bacteremia. So the bugs that are in the cavity in the tooth are in the bloodstream. Wow, fascinating, huh? That's that mouth to body connection, the oral systemic connection. And again, dentists treat teeth like they're pieces of bone, or there's a hole, we carve it out and we fill it, but really it's a systemic infection, right? Which can elevate CRP and things like that. So so flossing and brushing actually cause bacteremias. But if you're healthy and you're not doing all the things that we just talked about, eating the wrong diet and
using Listerine and all that.
Yeah, exactly right. Then that is okay. When we cut ourselves, we can get a bacteremia. But if we're healthy and our immune system is good, working well, then that's fine. But what if it isn't? What if you've been using a really strong mouthwash all your life and you've created the wrong environment and ratio of bugs to each other? What happens when that gets into the bloodstream down line, right? We don't really know. So brushing and flossing are important. I'm not against it. I'm not going to be the dentist that says it's bad for you, although some do. You're disrupting the biofilm. Again, that's that non-shedding surface. Non-shedding surfaces that pop out of the skin and the body get covered. The body's trying to deal with it. And the biofilm, with a poor diet, high in carbohydrates, and being washed away and scrubbed away too much, can be a problem. It can be overdeveloped, it can be too thick, it can prevent remineralization of the tooth. So essentially, flossing and brushing are good. You have to do it properly. It has to be done in a healthy mouth, and it can't be done, too much, too little. I don't want to scare people off from it because they're going to get performance anxiety, right? But there's a place for flossing. I would prefer not to use plastic, of course. Silk is great. They have non-synthetic flosses. Brushing is important, but brushing with a clean, not worn toothbrush is important. We can actually literally scrape away essential tooth structure by brushing incorrectly, and by brushing with an older toothbrush, a worn toothbrush. So what's the right thing to do? And I would say sit down with your dentist and really ask those questions. And many people are aware of this. They know, and they do ask the questions. So I would stay away from hydrogen peroxide. Anything that changes the pH in the mouth, I'd be careful with, and definitely brushing and flossing, but with that caveat that I mentioned. So
that's good. So basically, the kind of the controversy surrounding flossing is if you have dysbiosis of the oral canal, right? That by flossing or even vigorous brushing, you can release that bad bacteria. So as long as you're eating a healthy diet per se,
right.
And have good oral hygiene, that probably isn't. It's beneficial to floss and brush. Okay.
Yes.
Really awesome. And you have some videos on how to brush, which is really awesome. And I love how you have your flossing video at the end. You say, it's safe to floss and text at the same time.
With the floss stick, not flossing. Yeah, right.
Yeah, you have some great videos. So we'll have the links below this video too, so people can check that out.
Great,
but let's kind of transition a little bit to sleep and breathing at night. I think this is a huge aspect. Like I said, that seminar that I went to, which 800 physicians all throughout the world were there learning about sleep, and a big aspect of sleep, you can see sleep perturbations in the mouth, and that leads to all this systemic inflammation and metabolic issues. So let's dive into that.
Why talk to your dentist about sleep? And it's a great question. I wish it was discussed more, and I think it will be soon. But there are things that we can see. First of all, we see our patients more often, and we see that our patients tend to be more loyal because dental plans don't scare off patients. I mean, they tend to stay the same. You're only getting a $2,000 max, and people are used to paying out of pocket for dentistry. But in medicine, you always go with whatever plan your employer has, and most people are switching jobs every 3 to 5 years. So there's not that continuity. So I can see patients and I've seen patients from 2 years old to medical school, or or even specialty schools, and so that's handy because we get the baseline. We've seen the baseline. We see their parents. We see the family. We see them more often. We see them twice a year, sometimes 4 times a year. Young people don't go see a physician that often. Even some older people don't. So there's continuity there. And there are oral manifestations, several of them, we can talk about them, that a physician would not see or recognize. Some would, but they're just not trained to do it. Most physicians would refer to the mouth as the little black box. They just look past into the oral pharynx, and that's fine. I mean, I don't palpate, for liver disease and that kind of thing. So, and again, dentistry is a specialty. So, but there has to be some collaboration between the medical world and the dental world, and I think one of the areas will be in sleep apnea. So I see these things, and it's very plain to me that they have sleep apnea. It sometimes shocks them because their physician never mentioned it. Patients, if they're tired and run down, and they think, well, that's just modern life. I'm working hard. I go to bed late because I've got stuff to do for work. I got to get my kids to bed. I'm getting older. I'm not getting younger. I'm gaining weight because that's just kind of what everyone does, right? That's the norm. And really, that's not what the question we should be asking is, why am I so tired? But then how do you relay that to your physician? Do you ask them for an Epworth? Do you tell them you have a small airway and that you grind your teeth and you have a scalloped tongue and all those things? No, you don't, because you don't know that. But your dentist does, and your dentist can guide you. So technically, we cannot diagnose sleep apnea, but we're great at screening for it. We have everything we need. We got our patients on their back. We're throwing water in their back of their throat. If they're a mouth breather and they can't breathe through their nose, we can see that because they have to get up and spit a lot. I mean, they can't keep their mouth open. We can only work for short periods of time, and then they have to sit up. I mean, these are things that most physicians aren't getting when they, are checking for blood pressure and things like that. So we have that position, that unique position, and we should be capitalizing on that. It'd be good for the overall health of our patients. It'd also be good for the healthcare system. We'd be catching it sooner, and it's a root cause of many diseases, major diseases that cost a lot of money and cause a lot of harm and pain and affect the quality of our lives.
Yeah, and premature morbidity, and you talked about energy throughout the day. I mean, a lot of people are having coffee at 2, 3 o'clock. They can barely focus, and so forth. So I think, sleep is a primal, foundational aspect of our health. And so if we're grinding our teeth, I was watching your videos and read your book and stuff. So I was looking at kind of the signs and symptoms, because I was really surprised to learn about this, and my retainers are always like ground up on one side, so I have a personal interest in this, right? So if I didn't have a retainer, I would never know that I grind my teeth, and just by the fact that I grind my teeth, now I know that I might have some form of sleep apnea. And maybe let's get people interested by talking about some of the problems with sleep apnea. Oxidative stress, inflammation, hypoxia. Kind of talk about why sleep apnea is bad.
I mean, the list of what isn't caused by sleep apnea is way shorter. I used to tell my patients, give them a long list, and cancer wasn't on the list back then, and now it is. And I would always say, well, it's everything but cancer. But now it's breast cancer. I think prostate cancer is coming soon. There's Alzheimer's, insulin resistance, IBS. I mean, who knows what the effect is on the gut microbiome. I mean, we're just beginning to figure that out. So it's all encompassing. I tell my patients that if you can diet, you can try and lose weight, you can already be there and feel like you're doing well, but if you don't have that foundation of a good, deep 8 hours sleep, whatever, 7 hours, 9 hours, whatever it takes, but quality sleep, you don't have a foundation. I tell them it's like a pedestal. You get out of bed, and when you're standing on a foundation that's got dry rot in it, it's falling apart, you haven't gotten your growth hormone, you've been tossing and turning all night long, and your cortisol's been on all night, it never left, only growth hormone turns off the cortisol, then all that exercise and good dieting and the sacrificing you're making and the attempts and educating yourself on all that, that is going to be a lot more difficult to attain and keep if you don't have that foundation or that pedestal that you stand on. I mean, it's got to be solid. Right. It's got to be uplifting. It's got to be something that you can spring off of and do all those things and enjoy them. Plus, you'll reap the benefits of CrossFit or whatever you're doing. You'll get more of it.
Right. Yeah, it's interesting. I mean, all the circadian rhythm research and night shift workers, and you talk about increased risk of cancer just with sleep apnea. So this is all related, everything. And obesity, I mean, that's a huge thing. Everyone's trying to lose weight. I mean, the American population, I'm sure you've seen the stats, more than 70% are either overweight or obese. So we're seeing this in children as well. And people are blaming this on circadian rhythm disruption, blue light, artificial light. But if we do have breathing issues and airway issues, which I want to dive into now, people would never know that. And that's, I think, why you titled your book, that 8-hour sleep paradox, right? Because people are getting their sleep, but they're unrefreshed. They wake up groggy, they need coffee.
Well, we check off that box, I got my 8 hours. Yeah. And I should be good. Well, what was that 8 hours like? I mean, was it quality sleep? So you mentioned BMI has been on the rise, although we're seeing a dip now with children, which is nice to see, but let's hope it continues. And of course, you can gain weight in your airway, you can gain weight in your tongue. And of course, that just doesn't make it any bigger, and it doesn't make it easier to manage. So, what's coming first? Poor sleep, where when you wake up, you're always craving carbohydrates because you need the energy, and then you get the insulin resistance, and then, you start gaining weight. So it's all tied in. It's all part of the big equation. And so the airway is important. It collapses. I think a lot of people think our airway is constant. It's like a rigid tube, and it's not. It's the size of a tapioca straw. I mean, typically. I know it's really small, and we force food down there. And it's amazing what that airway does. It's got the voice box nearby. As we evolve, the voice box raised up close to the kink. I mean, dogs have a straight airway. They can eat and bark at the same time, and I mean, it's. We're unique in that regard. So is it a compromise? I mean, I don't know if that's what you want to call it, but it is not a perfect airway to begin with. And then we get improper development, lack of breastfeeding. We're not chewing hard foods at the time that we should be. We're eating, as babies, we're eating, smoothies and chopped up parade foods. And I mean, that's not what we were doing. We were eating probably raw or cured meats, and things were chewy, and that helped development. We had the high K2 levels and all the pasture raised, the wildness of our food supply. We had minerals. We had good airways. We developed with good airways, even though there's that built-in compromise. Well, now, we're not breastfeeding as much. We're drinking from sippy cups. We're slurping our food down. And what does that do? Well, it makes the whole lower face smaller, which has an effect on the airway, and then it becomes more difficult to breathe. Then we start gaining weight. Our BMIs are higher. Does that eventually lead to Alzheimer's? I mean, it all starts there. So the airway is really the essence of life. Yeah, if we can't breathe at night, and again, back to the tube, it's not a rigid tube. The tube collapses when the muscles around that tube are flaccid. And that is the definition of deep sleep, when all our muscles are paralyzed. They literally just let go. And, you know, are they resting? Is that the preferred state of sleep? I mean, obviously our bodies want that, they crave that.
So Dr. B, I don't want to interrupt you, but it sounds like it's almost like a paradox, right? The airway now is not as big as it used to be, but to get that deep sleep, we need to relax the muscles. So that's where that link kind of comes in.
Yeah, so that's the irony of it. I mean, why do we go into deep sleep and the airway collapses? You would think, I mean, why don't we have a rigid airway? And that's, I mean, I could go into that. There are probably some evolutionary reasons for that, but essentially that's it. And if we had a better airway, then the collapse wouldn't be as, the ramifications of the collapse wouldn't be as great. But that collapse is what we don't think about. We take it for granted. We take our airway for granted. Good sleep, deep sleep, restorative sleep is innate, but it's not guaranteed. And of course, if you gain weight in the airway, it gets smaller, and there are fat pads in the airway. The tongue can gain weight. You know, everyone thinks of it as a muscle. It is a muscle. It's an incredible muscle. But when it goes flaccid, it rolls up into a little ball. I mean, we think of it as being, you know, the Gene Simmons tongue, right? It's long and narrow. It can do things. I call it the alarmist of the mouth. It can pick out anything in the mouth. A little broken tooth, a little fracture, a little poppy seed or something caught. It's amazing what it does.
Right.
It's cleaning. It allows us to speak. It has taste buds. But when it goes to sleep, it loses its flat, you know, tone, and it just rolls up and it falls backwards, and then we make it worse by lying down. And I wonder if our ancestors actually lay flat. I wonder if we were curled up against the wall of a stone or a
tree,
you know,
or something.
Right.
Yeah.
And for a lot of my patients that refuse to wear a CPAP or get a sleep study, and they're older typically, and I tell them to buy a Lazy Boy. Get a Lazy Boy, keep your head higher than the rest of your body, and try and learn how to sleep in that, and it really works for them.
Wow.
Yeah. So the airway is interesting. Yeah, it's collapsing. Why is it collapsing? Well, I mean, it's a muscle. Our diaphragm's working, our heart's working, our rapid eye muscles, our eye movement muscles are moving, but that's it. So I guess we need that to really rest and slow down our metabolic rate. And you know, I wonder what grizzly bears are doing in hibernation. You know, what's their airway like?
Right. What comes to mind is the prevalence of dyspepsia and the need for proton pump inhibitors and reflux. And this was when I was doing a nutrition consults, like I was telling you, which were auxiliary. Pretty much every patient I worked with that was overweight, pre-diabetic, hypertensive was on a PPI, proton pump inhibitor, the purple pill, right, that's advertised on TV all the time. It's so prevalent, pervasive. Is that linked to this airway dysfunction?
It is. So on a correlative basis, I put that in my book. If we see GERD, we use this and grinding and lingual erosions, again, another oral manifestation. The stomach acids creep up at night with the snoring. We don't know why. We don't know what the mechanism is. There are several explanations. The vibration, you know, the relaxation, of course, of the lower esophageal sphincter. But the acids are there. We can see it as a dentist. We call them lingual erosions. So the erosion occurs on the inside of the teeth, because the teeth are usually together, the tongue's there. We see the erosions on the inside where the tooth meets the gum, and it's very characteristic. I mean, it can only be one thing. It's that unique. Now, if there can be erosions on other parts of the teeth, that's different. But lingual erosions, dry mouth in the morning, bruxism, GERD, patient complains of GERD. It's on our form for sleep apnea. So yeah, that's a real problem. And of course, those people are overweight. They got big neck sizes. You know, it's kind of this big multifactorial just combination of things that we can recognize it, we can see it, and we can see it early. I see kids regurgitating a lot of acids, stomach acids, and you know, certainly a lot of young adults, a lot of teenagers start doing that. So sleep's important, especially for a teenager.
Oh, big time.
Yeah, their brain's rebooting, and they need that growth hormone. They're developing. They're laying down new pathways in the brain.
Right. Yeah, it's huge. I remember in high school, I always wanted to fall asleep at like 3 o'clock. It was so hard to maintain. So very interesting. And you brought up neck size. That was on my mind of things to ask you. You know, when I wrote the book, Belly Fat Effect, and looking all about adipose tissue and the signs and symptoms of obesity beyond just body fat percentage and so forth, neck circumference kept coming up, and I didn't know what the link was there, so you just kind of solidified that. Yeah,
so certain neck sizes, you know, you can measure it 16, 17 inches, but here's the thing. So we look at neck size, but it's not absolute. There's a study out of Sweden. They took low BMI women under menopausal age, so from 20 to 50. These are healthy young women. The reason they took out menopause is because women catch up with men with sleep apnea, because the progesterone and estrogen are protective of the airway.
Wow.
Those are hormones that are protective of the airway muscles. But anyway, so they took the ideal, and these are people that did not have sleep apnea, of course. So it was an ideal group of patients, and half of them had sleep disorder breathing, and the neck sizes were small. I mean, so when I see a very small, petite woman who is in great shape and young and all that, I do suspect, and if there's grinding and other things, of course, then yeah, don't count them out because of neck size. That's not absolute.
Right.
Yeah.
It's just one piece of the puzzle. But
Exactly right. Yeah, it's an older piece of the puzzle.
Yeah.
And of course, that was our typical MO for a patient, was the big white Caucasian male, hugely overweight. You could hear him snoring in the waiting room, so sleeping, waiting for his appointment. I mean, that kind of thing. And the neck sizes were huge. So
Wow. So we know that the condition here is very prevalent and pervasive. A lot of people have sleep-related issues, sleep apnea, probably undiagnosed. So now we talked about all the bad stuff. Let's talk about the good stuff. What can we really do here?
I tell you, that's what we got to be doing more of. And if we can, as we discussed, if we can diagnose this earlier, then the solutions are typically easier. They may not require surgery. And of course, your life is better from that point on. But the three methods are essentially, in a nutshell, surgery, opening up the airway. There are many different methods. Some are falling out of favor. Some are now modifications of older types of surgeries with good results. Some surgeons are amazing what they can do for the airway. I've seen some great results. I always tell the patient, depending on the anatomy and how severe it is, let's try the other two, which is the oral appliance and CPAP or APAP. And it's a little box that you put by your bed. It's got a hose that goes to your nose or mouth. The better CPAPs and APAPs have, they're thinner, lighter. They have the hose coming from the back of the head. There's nothing worse than having a big hose on your nose, because that could affect your cartilage, and it's a lot of pressure. It's claustrophobic. They're improving that, but that's I think the one remedy. Solution to sleep apnea that most people are deadly afraid of. I mean, and I use the word deadly because they're going to die because they don't want that. They're dying slowly. So that's improving. Then there's the oral appliance. And again, the CPAP was invented, I think, in the 60s. It's rather new. Sleep apnea is a relatively new science and area of healthcare. The oral appliance has been around for about the same amount of time, but it was really an orthodontic device. It was used in children to help that lower forward growth of the face, and which ironically helps the airway too, but we didn't know that at the time. So,
interesting.
And then I guess they figured out, oh gosh, that person's snoring less with the Herbst appliance, is what they called it. It was named after a guy named Herbst. And
we have one here. I'm gonna move it out. So
there we go.
Watching,
Conveniently, right. So, I mean, this is a classic Herbst appliance. It's now called a mandibular advancement device, a MAD. I've seen it listed as a mandibular advancement appliance, MAA. It advances your jaw and it helps prevent
like
the collapse. Yeah, it's bulldog. It's kind of that, I mean, I'm like this at night, but it's better than being like this.
That's okay. You almost snored right there.
Right. And I can barely breathe in that position. And I only have mild sleep apnea. I have 12 interruptions per hour.
Okay.
When I wear a device like this, very similar to this, I have 0 interruptions.
Wow.
And that's not me saying that. That's going back and getting a verified sleep study, a split study, which I insist everyone get done, to verify the efficacy of the device. So you can also wear a CPAP or an APAP, and that's a machine that blows air into you, and it can get in your stomach and cause distension. You have to clean the tubing. You can get pneumonia from it, but it is the gold standard.
Okay.
And for me, I think this device and an APAP, which is an automatic version of the CPAP, I think may become a gold standard, because a lot of my patients that have severe sleep apnea, they can't wear the APAP because it's just blowing too much air. But you put this into throw this into the equation, advance the jaw a little bit so it doesn't collapse. The machine doesn't have to blow so hard, and it's automatic, so it's sensing that. So that's hybrid therapy, and that's a great solution. So try those first. It's all good. It's non-surgical. It works. It will increase the quality of your life. It'll square the life curve. You'll live longer. You'll be happier. You won't get those crazy food cravings. You'll make better decisions. We all know as healthcare practitioners that probably the best thing you can do in healthcare is to make the right decisions.
Right.
But if you're sleepy and foggy and disorientated and grumpy because you're not sleeping well, you're not going to make great healthcare decisions.
Right.
And I run into that all the time with my patients. especially men, they come in, I tell them they have sleep apnea, did it this morning, and they're like, yeah, I'm okay. I'm not wearing that thing. I'm good. I sleep well. Well, you can't assess your own sleep quality. I mean, because you're half asleep, right? So that's the thing, you know, to be active and proactive and be a good patient and take care of yourself, you got to be awake. You got to be well rested.
Yeah.
And that's the problem with sleep apnea, is it puts you into a state where you're in denial. You're more likely to be in denial. So surgery as a backup, and the CPAP, APAP, oral appliance, all three. 2 of the 3. It's, you got to have a good health care practitioner. You got to have a team approach. You got to have a good dentist. You have to have a good CPAP specialist, therapist who attaches and modifies the mask and gets you the right unit. And you have to have a good sleep medicine specialist, MD.
Right.
And that's what this book kind of talks about, is it kind of puts all that into one quick and easy book to read with lists and everything and check boxes, and because it's complicated. And and that's why I wrote the book. I saw my patients going through this. I'd refer them back, and they'd come back and say, oh, he doesn't want to do sleep study. And well, this is what you have to say. You have to fill out the Epworth, and you have to walk them through it. It's tough. It's not a oh, this hurts, I got to get it fixed kind of thing. Yeah. You have to know what questions to ask.
Right. Yeah, there's so much there to take away from what, first thing that comes to mind is the decision-making, the poor decision-making associated with sleep dysfunction. There was a study that showed that sleep deprivation and driving is as bad, like drunk drivers drive as bad as people that are sleep deprived.
Yeah.
So that's a big thing. I mean, accidents on the highway and all these other things are huge.
That's a really good point, because a lot of us will think, well, okay, so I have sleep apnea, who cares? I'm fine. But what about the guy driving, the truck driver, or your surgeon who's doing surgery on you? What if or the pilot who's flying your plane? What if he has sleep apnea? It affects all of us. Even though only 20 to 30% of the population has some form of sleep disorder breathing, we're all affected by it in some way or another.
Yeah. And so let's just break down the barriers in terms of like cost and stuff like that, ordering the CPAP, or sorry, the sleep study.
Right.
Is this pretty invasive? I mean, when I think of a sleep study, it sounds expensive.
Yeah, it's expensive. It depends on what part of the country you're in. Insurance will cover it, but you have to, prove your case, and unfortunately the insurance companies want you to be sick already before, like you have to have high blood pressure. You have to have a comorbidity of sleep apnea. You could go in and tell your doctor, well, I fell asleep at the wheel. That may help. High Epworth would help. That's a little quiz. That's a standard in the industry, that if you fill it out and you score a 9 or 10 or higher, the insurance company will listen. They'll cover it perhaps. But it's a little bit of a game, unfortunately. Ideally, there would be a cheaper sleep study, a PSG, attended sleep study, where you go to a lab and you sleep in a nice bed. My sleep study was on a Sleep Number bed. I had my own room. It was like a little Holiday Inn. It was clean. I had a TV. I had my own bathroom. It was right across the street. It's the clinic I work with now. And from there, I took a shower and went straight to work. So it's non-invasive. If you think glue with a little electrode stuck to your head is invasive, then you're out of luck. But it's actually a very interesting experience, and it tells you so much. Why wouldn't you want to know how well you're sleeping? Because that's what you're going to be doing every night for the rest of your life, and it's just going to get worse, right? Even if you are healthy and have a large airway. I mean, we tend to the airway gets worse over time, especially with women and menopause and all that, and certainly age. But it's not invasive. I get a lot of resistance on it, though. It's probably cost. I think the main reason is because they don't want to know that they don't sleep well because of the implications of that.
People have to change something in their life.
And in some countries, like in Europe, I mean, if you're a truck driver or a pilot, you are put on standby, and you have to verify with a device that wirelessly tells the doctor that you can continue operating that heavy machinery. And I do have some patients. It's voluntary at this point, and the FAA is grappling with that right now. Is where do they draw the line? When do pilots have to admit that they have sleep apnea and get a sleep study? Pilots take a lot of naps. The circadian rhythm is not great with the pilot. I mean,
and the nutrition. I've seen a lot of pilots eat McDonald's.
Oh yeah.
Right. So you add insult to injury.
Right.
Wow. Well, so what if a lot of our listeners are all about optimization, performance, whether it's work, sports related. So if someone like myself, right, who I don't have any manifestations or diseases at this point, if I wanted to pay cash for a sleep study, is that possible?
It is. I have a clinic here, and this is in the Bay Area, a very notoriously expensive area. You can get a PSG for $1,100.
Okay.
You can go right to the doctor. There's usually a doctor on staff in some of these clinics. They'll prescribe it for you.
Cool.
And you can just schedule the sleep study. You'll get the results. You can take that to your dentist and get this device. You can get a CPAP. You can buy. You can be part of a study. They have, I have resources, appendixes in the back of the book, in case these things are out of your reach financially. There are resources. You can buy a used CPAP. You can borrow one. You can be part of a study, get a CPAP that way. But these things can be done.
Yeah.
It's possible. But why wouldn't you? Totally. A lot of people would spend that healthcare dollar in other areas, and I would argue that, go back, take a few steps back, and work on the more important thing, the foundation, and maybe that problem will go away.
Right. This is huge. So let's talk about this device. What's involved with getting that done?
Well, I'm very familiar with this device. I've made thousands of these. I wear one. My wife wears one. I'm addicted to mine. My patients are addicted to it.
Cool.
Subconsciously, when your body goes into really deep sleep, somehow it just knows that it's this. So whatever this may be uncomfortable, your jaw's pushed forward. If I were to keep that position for a long time, I'd get tired, but this is keeping you in that position. In the beginning when I wore this, it was kind of like, wow, I would put it on at night and I'm like, oh, that's way out there. But then the next day you're not aware of it. It's been 3 or 4 years now, and I go back and forth between the two positions and it's seamless. So, but there is a transitional period. I would say 99% of the patients love this out of the box.
Wow.
They love it so much that they put up with the changes in bite and the soreness of the jaw, and it gets advanced slowly. You add little spacers and you titrate or calibrate the device and you push it out slowly. You don't do it suddenly. Right. So they put up with it because that first night of sleep is like, whoa, something's different. I don't remember anything. Wow. It's amnesic. It's my spouse woke me up in the morning and said, oh my God, you were quiet. You were silent. I love it. I need one, that kind of thing. So they're expensive, unfortunately. They range between $2,500 to $4,500. It's a lot of lab work, a lot of work for the dentist. It's all labor.
Right.
Insurance will pay for it. You have to have a PSG, you have to have your sleep study, you have to have a prescription from a sleep MD specialist. But that's happening more and more because the MDs are on board now. They see it, they see the studies. It's more for someone who has mild to moderate sleep apnea, although I've treated people with severe. They've given up on the CPAP. These are people that have AHIs of 70 or 80. That's more than every 30 seconds they're waking up.
Wow. They
go into deep sleep and they come right back out because that airway just closes and they're suffocating.
Wow.
That's and plus, it's almost. I didn't say this in the book because some people that read it felt it was a bit extreme, but my analogy for severe sleep apnea or even moderate sleep apnea is it's a form of waterboarding while you're unconscious. And does that leak through to the rest of your day? Absolutely. Anxiety, you've been fighting for your life at night.
Right.
And the adrenal glands are going, your fight or flight response is going. That's why waterboarding is used, because it gets results quickly because you're simulating death while you're alive. That choking lack of oxygen instinct to regain your breath it's primal. It's strong and it scares the living out of you. It's terrible. So that's happening on a milder level, but it's happening more often. It's happening all night long. So what kind of result does that give you during the day?
Oh my gosh.
A lot of stress and fear. So this has helped a lot of people that are anxious. So it has to be delivered by the right person,
right.
And that's easy to find. You can go to the AADSM website and you can find a doctor that specializes in doing this, and that we're seeing that more and more, and we're getting people that are accredited in it, and the MDs are on board. So this is a very viable alternative. But again, mostly for mild to moderate.
Okay.
If your AHI is over, I would say the limit maybe should be 25. But again, I've treated a lot of people that are at 35, 75, and we've got them down to 0.
Wow.
Or we would go to hybrid therapy. If they've given up on the APAP, then we would tell them, okay, let's calibrate the device, let's get you down. I have a patient, an older woman in her 80s who had an AHI of 79, and she came in because her son had come in for one of these, and And she had told her doctor, I'm just never wearing that APAP, CPAP again. So I said, well, listen, okay, we're not really supposed to do this for you because of the following reasons. But if you promise me that you'll try the APAP, if I make you one of these devices at some point in time when I ask you to, and if you do that, then we can try and make this work. So I didn't tell her about the hybrid therapy because it meant telling her that she's going to have to wear an APAP again.
Right.
It took us about 6 to 8 months. We got her down to 19 interruptions per hour, which I think was huge, but that's still moderate sleep apnea. Then I introduced the idea of an APAP. She was wearing a CPAP. APAPs are, react to the environment. So it will ramp down, it will ramp up, the air pressure, it's not a set air pressure.
Right.
So I said, well, let's get you an APAP. Let's try the APAP with this in place and see what happens. Well, to this day, she's wearing her APAP because the thing isn't blowing as hard. Wow. And this is what made the difference. So now she has an AHI of like 2 or 3.
That's amazing.
And yeah, so again, it's as much as it is scientific and clinical, it is also very artistic. You really have to, every patient's different.
Mm-hmm. And the organization you mentioned was the Dentist for Sleep Medicine?
Yeah, so that's the AADSM. I'm a member. There's the AASM, but the AADSM.org and it's in the back of the book in the appendix. It's a great resource. That's where dentists and physicians are working on this issue together. Wow. And if you, as a end user, as a patient, you can go to their website and you can,
search for someone in the area.
Dial in based on area code, zip code, whatever.
That's fantastic.
Right, yeah.
This is I go to a lot of seminars and read a lot of research. I've never heard of this. I mean, this is why this message is so important.
That's why we're here, right? Yeah.
I want to interview
get this message out. That's why this book exists.
Yeah.
And, yeah.
I really commend you. I mean, we could talk for hours, I'm sure, about all these different variables and aspects. So you got the great book, great YouTube channel, Ask the Dentist, right, is your channel?
Yep.
Fantastic. So we have 3 final questions that we ask every guest on the show.
Right, I seem to remember that. I didn't bone up for it, but yeah.
It's better if it's on the fly anyway.
Absolutely.
So if there was one herb, nutrient, botanical, or whole food substance that you just could not live without, what would it be?
Well, I'm a dentist. That's a unfair question. I would say K2, vitamin K2.
Nice.
Because it would help a lot of young people as they develop. They would develop better, bone structure and potentially a better airway. So, and that of course is so life-changing. Why not start off with a good airway? So I would say vitamin K2.
Fantastic.
Yeah.
Now there's the MK7, MK4. Do you dive into that detail?
I do. One's water soluble, one's fat soluble. So I'm taking it 3 times a day.
Cool.
Take a mixture of MK4 and MK7. I recommend to my patients. It's kind of hard to get. It's been changing. If you go to Amazon.com, and you go to many different suppliers, first they'll add the 7 and the 4, and now they've joined the MK4 and MK7, but it's in the wrong ratios. And if you read the great book, I think it's one of the best health books in the last 10 years that I've read, the Calcium Paradox. Kate Room-Blue wrote it. Great book. She tells you exactly what you need. And the child's dosage is still, it's not an unsafe thing to take. You can't really take too much. But yes, I do get into that, definitely.
That's awesome. Yeah. Okay, so we'll have to put links below that. Some of that research is really fantastic. So you're a busy guy, you have a family, you wrote a great book, busy practice. We want to know what your morning routine is. So I'm curious, do you get up, do you do anything in particular that's important or pertinent to your health?
That's a good question. I think the morning routine is important. You read about it occasionally. I'm always interested in other people's morning routines. So since I've been wearing my device, my morning routine has changed. It used to be where I would sleep to the alarm, wake up and get to work, take a shower and grab a quick breakfast. But my morning routine now is I get up, I hit this satiation reflex where all of a sudden my body just wakes up. It's still dark. We have blackout curtains. We have all the right things in the room, of course, the right pillows, and it's quiet. It's a dead room. But I'll wake up depending on when I go to bed. If I go to bed later, you notice the difference. And I'll sleep a little bit later. If I go to bed too early, which sometimes I do, I'm a little tired. I've done a lot of CrossFit, a long mountain bike ride, a lot of skiing, and then you're exhausted. And that's not tiredness, sleepy tiredness. You go to sleep and then I'm up at 5 o'clock instead of 5:30 because you went to bed a little earlier. So I hit that satiation response. I wake up, I jump out of bed, I put my bathrobe on, I go downstairs, I have some smoked salmon, as we talked about earlier, some pastured eggs, I read the newspaper, and I listen to music if I can.
Nice.
And it depends on what's coming. If it's work, it's energetic music. And then I get into my electric car, I grab the dog, the service dog, and I come to work. So it's just kind of quiet time, downtime, And I do take a shower, of course, and I use peppermint soap to wake up the brain. So
there you go.
Yeah,
that's
it.
fantastic.
Very simple. Yeah.
2 questions on that. Do you drive a Tesla?
I do not.
Okay,
Yes,
just curious.
I know. Everyone else in the valley does,
Yeah.
but no, I drive a little Fiat.
Right on.
Teslas are expensive. But,
They really are.
But the Fiat does the job. Gets me in the carpool lane. In this valley, it's important.
Yeah.
And the price is right. So
regarding your sleep, okay,
Right.
I'm really curious. As
Yeah.
a lifelong backcountry skier, we know that you're climbing extensively.
Yeah.
So let's talk about how having this device and taking sleep to the whole new level, how has that affected your exercise performance?
it's definitely given me more endurance. And backcountry skiing, you're slogging along with 50 pounds on your back, and it's a long haul. So it used to be where I would do well, get tired, eat some carbs, good carbs, complex carbs, right?
Yeah.
And then get the second wind, and I could go all day. But now it's a lot different. I definitely feel better. Muscle mass is easier to gain. I'm not as out of breath. I do bring this when I camp in the snow. I mean, that's convenient, right?
Right.
I always want my airway open. I would like to maybe develop something someday where there's a daytime version of this.
Oh, cool.
Because when I'm mountain biking or skiing, sometimes I'll make sure that, my airway's open. In mountaineering, there's that pressure breathing.
Right.
We know what that is. That's, to oxygenate the blood. Partial pressure is different at high altitude. So, breathing's everything. It's the essence of life. Oxygen to the brain and to the rest of the body.
Right.
And you're gonna do better in any area if you're breathing properly. Of course, at night, if you're sleeping well, then your daytime, your day will be much better.
Totally.
Obviously, yeah.
The reason why I asked that is that's a very objective. If you could climb at a certain rate per hour, or go climb 4,000 feet versus 5,000 feet in one day, for example, and still have some gas in the tank. So that's awesome.
I think I would measure that by skiing, alpine downhill skiing, because that's something I do every weekend.
Oh, wow.
And so that would be a better measure. Backcountry skiing is so erratic, and as you get older, and it's usually done in the springtime, late winter to spring. So it would be more mountain biking, and so mountain biking definitely. Skiing, absolutely. Skiing is a very rough sport. A lot of lactic acid in the muscles, and there's got to be a lot of cleanup done. So definitely, no doubt in my mind. I mean, can I quantitatively give you some stats and data?
No, I wasn't.
No, but I mean, I do a lot of hiking when I'm at the ski resort. You compare yourself to your buddies that aren't sleeping well, and of course there are other factors, of course, but I don't know, if you want to be your best in all areas, certainly in keeping muscle mass, gaining new muscle mass, endurance sports. I'm not a big aerobic guy where I'll do wind sprints, but I won't go for long. Vmax is lower for me now, of course, but gotta sleep, man.
That's awesome.
That makes your day much better and safer too. Much safer. You're not gonna
have an
you're
accident.
Coming to the crux of a cornice and you've got your ice axe in there, you're hanging there. It's like there have been moments where you just needed that little bit of energy and mental aptitude and positive attitude. I mean, that all comes from a good night's sleep. If you haven't slept well, you're not going to be able to pilot a plane very well. You're going to make mistakes. I mean, look at all the major industrial accidents. Exxon Valdez, the Selby incident in England. There was that Bronx train that went off the tracks about 2 years ago. It was funny because Google News put up a picture of the guy, and he had a big neck, and I saw his teeth, and he just had that tired look. And I tweeted. A lot of physicians follow me on my Twitter feed, and I said, "Oh, probably sleep apnea." And of course, they emailed me back and said, "Come on, Burhenne." A year later, it was last December, the study came out, and he had undiagnosed sleep apnea. He fell asleep. Came around the turn too fast. So that's how it affects everyone. I mean, you may have a perfect airway, you may think it's fine, but let's all get on the same base here. Let's start breathing well. We'll be happier. Maybe our politicians will be more reasonable. I mean, our pilots won't make mistakes. Train operators, our surgeons, our kids will be smarter. Less ADD, ADHD, maybe less crime. I don't know. I mean, again, sleep.
This is huge. Yeah, this is, I think, Trump's nutrition, right? Because you can, we always say the diet is everything, right? Fitness and bodybuilding and disease, but I think sleep has a hierarchy over
sleep,
that.
Sleep trumps pretty much everything. I agree with that.
Yeah, that's fantastic. Yeah, what comes to mind too, I remember I was in Chicago when one of the CTA trains crashed into, not a lot of people, I don't think anyone died or got injured, but the driver admitted, it was in, what's the airport? Not Midway, but the other one. O'Hare, yeah. And so she said, I fell asleep, so it's kind of interesting that you hear about this.
And that's a hard thing to admit because, you have no control over that.
Right.
When you're tired, your body wants to shut down.
Yeah.
What do? You can be honest about it, and that's a tough thing to admit. But she probably didn't, no one told her.
Right.
She thought it was normal. She was working hard, maybe split shifts.
Yeah. I wasn't sleeping well to begin with and stuff like that.
Right.
So you mentioned politicians, so that's one of our final questions. If we were to bump shoulders with a politician of sorts or someone from the World Health Organization, just have 30 or 60 seconds to share with them a soundbite, a tip. What would you want them to know?
Ooh, God, that is a big question. It has to be health-oriented or anything?
It can be anything related, but something around health. But it could be about nutrition, food policy, sleep.
Yeah, I would say probably, and this is not me saying it, this is Deepak Chopra, I think, the emancipation of women. I think that would fix a lot of problems in this world. Yeah, health as well, because they're better at health.
Yeah.
They would take, they're the ones who nourish our babies, and in third world countries especially, they're breastfeeding. Emancipating women would clean up a lot of stuff.
Yeah. Fantastic. Well, Dr. Mark, we really appreciate you coming on the show. The 8-Hour Sleep Paradox, amazing book.
Thank you.
And your website and resource again is aciddentist.com. So do you have any free gifts or downloadable items where people can kind of learn more about?
They can get a free chapter on Amazon, get a sense of the first chapter. I think that pulls people in. We've got lots of great advice on the website, and they have access to my email if they have a question. So I try and get to the cases that I can fix for them, so I get some crazy emails, of course, that, I wouldn't know where to start, but, access to me, I'm happy to help. It's my mission to educate and to open up, areas like this to the everyday patient. Democratization of healthcare.
Yeah, it's much needed. Really appreciate your work.
Thanks for having me.
on the
It was
show.
fun. Yeah,
this is a great time.
Thanks.